we'll get going. Yeah, so the first thing I just thought I'd cover is sort of general tips about anoscopy. So I'll go over how to take a respiratory history, and then how to do a respiratory exam after that as well. I'll try and aim for probably about 45-50 minutes, and then I've got a case at the end which we can run through, which is quite a core case. Yeah, so I guess the first thing I want to say is read the brief carefully. You get about a minute, 2 minutes just before you start your station, where you get a little brief. So it's important to read exactly what the brief says, because it might not say take a whole history. It might say take just the presenting complaint, just the history of presenting complaint. So it's very important to just read very carefully and basically do what they ask you to do. Be friendly and polite, that's obvious, but just be extra friendly and extra polite. Be empathetic when necessary. So often they like to throw in little clues. So the patient might say, "Oh, I've been having a couple of off days," or it might not be as obvious. It might not be as obvious as that. So be empathetic and sort of listen out for clues and pick up on verbal and non-verbal cues when you're going through your history and exam. Establish a good rapport, I think, is really important. I'll talk a bit later about how to establish some top tips about how to establish a good rapport. Eye contact, I found examiners have told me a couple of times about eye contact. It's just something you take for granted. But obviously look the patient in the eye when you're talking to them. It's just, it's just common sense. And then, as everyone's probably already told you before, start off with open questions, and then listen intently. It's sort of active listening, so use your body language to sort of maybe have a slight lean forward posture, and make sure you listen intently. And as I said, listen out for cues about when you might need to step in. So when you're taking a history, it's not necessarily just about getting straight to the diagnosis at the end. Obviously, it's great if you can get to the diagnosis at the end, but there's lots of marks for all the different parts of the history that you'll need to cover. So it's important to have a step-by-step method that's yours, that I'll go through in a second, that you follow and work through, just so you cover all the person points and all the history, so you don't miss any big marks. So yes, obviously getting to the diagnosis and getting the right answer, if there is one, is very important, but there's lots of marks for the other parts of the history as well. So you've probably all seen this before. This is just the general method of how to take a history. So you start off with your introduction, then it's presenting complaints, so what have they actually come in to see you with. History of presenting complaints, so basically asked in detail about exactly what they've come in with, which obviously we'll go through in a sec for the respiratory system. Past medical and surgical history, anything that's relevant. Medication history, so what medications they're taking, and allergies, obviously very important. Social history, a bit about their life outside of what's brought them in, anything that may give you a clue as to what may be causing their problem. And then family history, review of systems, conclusion, and then if time, further investigations that you might do. I've always found it useful to jot these down on like the piece of paper that you get just before the station starts, because obviously everyone's very nervous when they go into OSCE, and if you lose your way at all, it's helpful to just have this sort of outline written down on a piece of paper, just so that if you ever lose your way, you can come back and think, right, I've done my medication history, I now need to move on to my social history, for example. So the way that I've always learned for OSCE, obviously everyone does it differently, is I like to think of the common conditions that for each system. So obviously we're talking about respiratory, so these are the main common conditions that you'll be examined on. There are obviously others, so it's not an extensive list. So I like to think of these conditions and then ask questions that are pertinent to these sorts of things. So asthma is common, COPD, pneumonia, lung cancer, ILD is interstitial lung disease. So those weird conditions that some people try and teach you about that I always found very confusing. Pulmonary fibrosis is an example of interstitial lung disease, if you want an example. A PE, so a clot in your lungs, is very important, because it's probably one of those things that's going to kill the patient the quickest. It's always an important one to rule out. Tuberculosis is slightly less common, especially nowadays, and especially the country we live in, but it's always worth it's always worth considering. And then heart failure as well. It's more of a cardiovascular, but obviously has respiratory implications because of fluid on the lungs and things like that. So the introduction I find is I think is one of the most important parts of the entire history station. It's the first impression that the patient and the examiner get of you. So a slick introduction helps build not only rapport with the examiner, but not only build rapport with the patient, but also with the examiner as well. And if the examiner likes your introduction and you've got a very slick introduction, then it does help with the rest of the station. It sort of sets you off on the right foot. So it's always important to introduce yourself, so a full name, who you are. So, hi, my name's Joseph Pearman. I'm a 5th-year medical student here at the University of Liverpool. That's very clear. It's very concise. Don't forget to wash your hands. It can be a bit of a panic as soon as you walk in. You've got all these thoughts running around your head, but don't forget the little pump that's usually on the table. So please don't forget to wash your hands in the A-lift technique. It's important to confirm the patient's name and date of birth. So that's usually the first thing I ask the patient, just to make sure you're talking to the right person, because if you're not talking to the right person, it's going to be a strange old station. And then you can check their wristband. They may or may not be wearing a wristband, but it's usually nice to check. I remember I was told in my younger years, ask if you can take a seat. It sounds a bit false and a bit forced, but it does help build rapport with the patient. That you're sort of allowing them that they're allowing you to come and have a chat with them. It's important to explain exactly what you'll be doing. So I'll be asking you a few questions about what's brought you in, just so we can try and help you with whatever's brought them in. And don't forget to ask consent. You need their permission to talk to them. If you don't ask consent, you might not be allowed, or they might turn around and say, well, actually, this patient doesn't want to talk to you. So make sure to ask for consent before you begin. So these are the 5 main presenter complaints that will probably come up in the respiratory history. So shortness of breath, cough, hemoptysis, which is coughing up blood, wheeze, and chest pain. So it might be one of these, it might be 2 of these, it might be an amalgamation of all 5. But it's important to ask about all of them, even if 4 of them are not the presenter complaint. So a patient might come in saying, I've been short of breath for the last week. You have to ask, do they have a cough? Have they been coughing up blood? Do they have a wheeze? Do they have chest pain? So even though some symptoms might not necessarily be the presenter complaint, it is important to still to cover them. So let's cover some of them. Fine. So history presenter complaint. So this is basically covering in detail exactly what's happened with their presenter complaint. So say their presenter complaint is shortness of breath, you need to ask everything in detail to try and get to the grips about what sort of shortness of breath or what sort of chest pain that they've been having. So Socrates, I'm sure you've all heard of, is a pretty good place to start. People mainly associate it with pain, which it probably is most associated with pain, but can be very relevant for a lot of other symptoms. So Socrates is written there, so it's site, onset, character, radiation. Obviously, that's more of a pain thing. Any associated symptoms, the time course, any exacerbating or relieving factors, and then the severity of whatever's going on. So that's more of a patient's perspective of exactly what's going on. And as I said, it's important to ask about all the respiratory symptoms, even if they're not the source of the presenting complaint. So shortness of breath. Obviously, you can Socrates it, and you can Socrates it as much as you like, and a lot of them are relevant, but I've just put some of the important points down here. So when did it start? How long it's been going on for? So is it an acute shortness of breath versus something that's been going on for a long period of time? So for example, an acute shortness of breath might be more like a pulmonary embolism versus a chronic shortness of breath, which might be something like an asthma or a COPD. When do they get short of breath? Is it all the time? Is it on exertion? Is it going up the stairs? Obviously, it's important to try and get to grips with exactly what they mean. Is it walking up a big hill? Because that might be, that might be perfectly understandable for someone to get out of breath walking up a really big hill. And try and get an idea of what baseline is. How much has this changed from baseline? Because their baseline might be shortness of breath at rest. Or their baseline might be, actually, I can only get up half a flight of stairs, and now I can't even get up 2 steps. So it's important to try and have an idea about what baseline is and how much it's changed. How severe they think their shortness of breath is. So this sort of gives you an idea of the functional status of the patient. So functional status is sort of how well they can cope with everyday life. And we call it ADL, so activity of daily living. So can they talk in 4 sentences? Can they walk up a flight of stairs? Can they go to the shops? Can they wash themselves? Can they make tea? Can they wash the clothes? Can they do sort of the day-to-day things that maybe they used to take for granted, but now actually they find quite hard. It's important to ask about diurnal variation. So diurnal variation do the symptoms change throughout the day? So for example, I've put down asthma there because diurnal variation is a very common symptom in asthma. So it's worse in the morning and worse in the evening. Actually, throughout the day, it gets sort of slightly better. And relationship to position. So is it worse when lying down? This is something called orthopnea. This is seen in heart failure. And then if it is worse when lying down, it's often worth asking sort of how many pillows do they use at night. And this gives a quantifiable way of us sort of measuring how severe their shortness of breath may be. Yeah. So the next big one is obviously cough. Is obviously very pertinent to the respiratory system. So again, when did it start? How long it's been going on for? And how often do they cough? Do they cough all the time? Is it only when they run? Only when they exercise? Or only when they're around their dog or around their cat or around sort of very dusty places with asthmatic patients? That's very key to ask. And the other thing to ask with cough, is it dry cough or is it productive cough? And if they say it's productive cough, then we need to, I know it's a bit horrible and it's not very nice to ask, but we need to ask more about what sort of sputum they're bringing up, what color, what thickness, how much. Obviously, how much is, as you can understand, quite hard to answer. But is it tablespoons all the time, or is it just a little bit sort of every now and again? And is there any blood? So I've put a few examples of the conditions on the side there that are pertinent to this. So dry cough, interstitial lung disease is a very common cause of a dry cough, as is a side effect of ACE inhibitors. Obviously, ACE inhibitors are used for blood pressure and in treatment for heart failure, and their main side effect is a dry cough. Productive cough with green sputum, obviously think a lower respiratory tract infection, so think something like pneumonia. And a COPD patient has a chronic productive cough with green sputum, so long-term productive cough. The classic heart failure cough is a productive cough with pink frothy sputum. I'm not actually sure in clinical practice how reliable that is, but that's the textbook definition. So keep an eye out for a productive cough with pink frothy sputum. And then a productive cough with hemoptysis. So if you're coughing up blood, it's important to think about sort of lung cancer or some other tumours that may be causing that. And then obviously with the times, it's important to ask any loss of taste, any loss of smell, any chronic fatigue that absolutely tires the patient out, to think of some COVID-19 symptoms.
You could have it all day long.
Yeah, so hemoptysis, so this is coughing up blood. So again, when did it start? How long has it been going on for? Is it a persistent thing, or is it something that's one-off? Again, the volume of hemoptysis is key. Is it just sort of little streaks in sputum, or is it more purulent? By purulent, we mean is it sort of copious amounts of blood? Because that could be more something like varices associated with things like alcoholic liver disease, as opposed to sort of small streaks of blood and sputum, which could be something like a PE, a COVID, or a tumour. And then again, associated symptoms that are very important with someone that's coming in with coughing up blood: any fever, any weight loss. Obviously, weight loss points to malignancy, tuberculosis. Any recent travel. Recent travel is a very important question to ask. I'll cover a bit more about that later, but that's a key tuberculosis feature. Any chest pain. Someone with PE will get chest pain and hemoptysis. That's sort of the classic finding. And then night sweats are common in both malignancy and tuberculosis. So it's often important to ask sort of, are they waking up in the middle of the night drenched in sweat? How many times do they have to change their pajamas? How many times do they have to change their bed sheets? It's questions like that that are useful to try and quantify how bad their night sweats are. And again, I've just put a couple of things on the side that I've already run through. Wheeze, again, wheeze is another common symptom, but I think less pertinent. No, I guess it is pertinent to a respiratory exam. The age of patient for a wheeze is very important. A young patient with a wheeze, you're thinking something like asthma. An old patient with a wheeze, you're thinking something like COPD or even a tumour, which I'll cover later when we do the examination. So again, when did it start? How long has it been going on for? When does the wheeze occur? So does it occur in the morning? Does it occur in the evening? That diurnal variation we were talking about with asthmatics. Does it occur in the cold weather, with exercise, animals and dust? They're all very key points for asthmatics. So asthmatic triggers, so exercise, animals, dust. And then is there any weight loss? So weight loss I put down there because we need to think about a tumour, because a tumour can sometimes give you a wheeze if it's blocking or constricting one of the airways in your lungs. Chest pain, Socrates is obviously perfect for chest pain. So just work through your Socrates and you'll pretty much cover most of the pertinent points for chest pain. Pleuritic chest pain is important from a respiratory standpoint because pleuritic chest pain is what you get with someone with a PE. So pleuritic chest pain, the exact definition is the pain is worse when you take a deep breath in, so worse on inspiration. And pleuritic chest pain is also worse when the patient coughs. So they're two sort of signs that you can pick up for a PE. Again, any associated hemoptysis, again, thinking PE, any associated weight loss. You can often get some chest pain with tumours. It's not particularly that characteristic, but you can often get chest pain. And then any associated asthma symptoms. So people might think chest pain is more of a chest tightness. So it's important to try and differentiate between the two. And another relevant respiratory symptom, so weight loss, I've already covered with things like tuberculosis and tumours. Night sweats, again, tuberculosis and tumours. Fever for infection, fatigue for infection and COVID. It's quite an important COVID symptom. Hoarse voice, again, for a tumour that's maybe slightly higher up in the airways. Leg swelling and calf pain I've put down because they're the two DVT symptoms, and often DVTs can predate a PE. And then travel history. So we'll come to travel history in a second. I like to then do review of systems at this point. So this is just sort of a top to toe, head to toe check to make sure you've covered all the systems, to make sure you haven't missed anything. So I basically just work from the top down. So any fits, faints or falls, that pretty much covers the main sort of neurology symptoms. Any visual disturbances, any headaches, obviously you'd then ask any shortness of breath, but you've already covered that in your history. Any palpitations, so I probably shouldn't have put palpitations there. It's important to not use jargon as well. That's another important point. So try and avoid using lots of medical jargon in your history. So because people might not know what palpitations are. So do you have any abnormal heartbeats, or have you ever found your heart racing a bit too fast? Might be a slightly better way of phrasing it. Any tummy pain, ask about the waterworks, ask about their bowels, what's normal for them, and then any rashes and any joint pains or joint aches. So that's a bit of a top to toe review of systems. Ice. This comes up again and again and again, and I'm sure if you've been revising for your Foskeys and Oskies, this will be the bane of your life. I've put it in here, but it's not something that should just be done here. It's something that should be done throughout every consultation, and there are so many marks for it in the exam. It's often hard to try and formulate your questions because it sounds a bit false and it sounds a bit fake, but it's important to remember it because you will lose marks if you leave it out. So it stands for ideas, concerns and expectations, and essentially in terms of the ideas, it's what do you think the problem is, what do you think could be causing your chest pain, or what do you think could be causing your hemoptysis, for example. Ask about the patient concerns. What are your concerns? What are you most concerned about? What worries you the most? They might say, I'm worried about taking time off work, or I'm worried about not being able to look after my dad, and that sort of adds another sort of layer to your history, and it shows you're thinking about things from the patient's perspective, which is always nice. And then expectations. I always find this the hardest one to ask about. So it's, what were you hoping I could do for you today? So they might come in and say, actually, all I want is antibiotics, and I just want to go home with some antibiotics, and everything will be okay. And so ICE is often really hard to formulate into your history, but it's something that's really important. Any questions from anyone? I appreciate I'm going quite quickly, just because there's a lot to cover, but any questions from anyone so far? If not, I will carry on. So past medical and surgical history. So essentially just ask them, do you suffer from any medical conditions? They might say yes, they might say no. If they say yes, when were they diagnosed? How is it managed? Is it managed by tablets? Is it managed by surgeries? Is it managed by physio? Is it managed by however? And then how many hospital admissions have you had in the last year? This is very important for asthma because it helps to determine asthma severity. So important to ask how many times I've been in the hospital in the last year. Have you had any surgery is an important question, especially recent surgery. So in the last couple of weeks, because surgery, obviously one of the triad of risk factors for blood clots is recent immobility and recent surgery, endothelial damage. So it's important to ask about recent surgery and how long the hospital stay was after that. Do they have a very atopic family, or are they a very atopic person? So do they get hay fever? Do they get eczema? And obviously the final bit of the triad is asthma. Any history of malignancy, so that's any lung malignancies or any other malignancies. So thinking of potential metastatic spread to the lungs from other parts of the body. And then are your vaccinations up to date? So we're thinking influenza, because obviously most people get the flu vaccine every year. Some people have had the TB vaccine, and then obviously now pertinent is the COVID vaccine. Medication history, again, is very important. So do you take any medications? So what current medications are on? Try and get the list. Try and get a dose. Try and get the names if you possibly can. I appreciate for some patients, some patients are on quite a few, so it's hard to get the full list. And any recently stopped medications are important because sometimes they can have a bit of a long-lasting effect on the cardiovascular systems. It's important to ask about recently stopped medications. And any over-the-counter medications and herbal remedies. These are very important. St. John's wort, I'm sure you've all heard of, keeps on popping up over and over and over again in various textbooks because it interacts with warfarin. So it's not necessarily that relevant to the respiratory system, but it's important to make sure they're not taking any weird and wonderful things from over the counter. And do they have allergies? This is one of the most important things in the whole history. So do not forget to ask, do they have any allergies? Some people might say yes, some allergic to penicillin, for example. And if so, you have to ask what happens when they take the penicillin. So what happened that one time that you took penicillin? Was it just a tummy upset, or was it a rash, airway compromise, angioedema, the whole works? Because it may get to a life or death situation where actually we need to give you, or the doctors need to give you penicillin to save your life, for example. And actually, if all you get is stomach upset, then it's important that we know that. Some people, when you ask, do they take medications? They say no, and then you actually find out they take inhalers, they take insulin, they take the pills. That often things that people take very frequently and very commonly, they sort of forget that they're a medication that they take. So it's maybe worth asking, especially inhalers for respiratory history. Do you take it? Do you have any inhalers? Do you take any insulin? And do you take the contraceptive pill? And these 5 that I've written down here, these are just some drugs that are very pertinent to the respiratory system. So NSAIDs, beta blockers, they're both relatively contraindicated in asthmatics. So it's worth keeping an eye on them. Amiodarone is a horrendous drug. It's an antiarrhythmic and can cause some pretty bad lung fibrosis, as can methotrexate and as can bleomycin. So methotrexate is used for rheumatoid and used in some cancers, and bleomycin is used for treatment for some cancers as well. So the last 3 are probably slightly more niche and slightly rarer, but NSAIDs and beta blockers certainly certainly far more common. So it's worth making sure that they're not on either of them. Social history, again, up there with allergies. Smoking, especially for the respiratory system, is very important. It's important for actually every history you'll ever take, but especially for the respiratory system, because the lungs are obviously directly impacted in someone who smokes. Have they ever smoked? They may have quit in the past. So if so, how many per day and for how long? So we need to try and figure out in pack years. That's a nice little way to quantify. So pack years is 20 cigarettes a day for a year is 1 pack year. So it's sort of like a universal measure of how much someone has smoked throughout their lifetime. So that'll be a nice thing to work out. I put down there, have they ever considered quitting? It can often be a hard question to ask, but sometimes they may turn around and say, actually, yes, you know what, I have been thinking about quitting. I just need that extra bit of support to try and help me to quit. So it shows you're sort of helping them with that. Alcohol and recreational drugs, that again is often a hard question to ask because it's quite a personal question. So I usually just say, I've got to ask some questions now about your social life. These are questions that we ask everyone. So it's nothing personal to you, just to make sure that we're not, that they know that we're not sort of targeting just them. And again, trying to quantify how much alcohol they drink in a week in units. Occupation is important for respiratory because there are some, especially for the interstitial lung diseases, occupation is really important. So do they work in a coal factory? Do they work in a mine? Have they ever worked with asbestos? So asbestos can cause something called mesothelioma, which is sort of a cancer of your pleura. So it's important to ask about occupation and what they may or may not have done in the past. Pets at home, again, is an important one. So obviously the fact that pets can be a source of allergies. So important to ask if there's any pets at home, whether there's been new pets at home that may have triggered the patient's symptoms. And now I've put down ADL, so activities of daily living. How are they with washing? How are they with walking to the shops? How are they with cleaning, cooking their dinner, and things like that? And then exercise tolerance and mobility. This is something that comes up a lot in A&E especially. So how's your exercise tolerance? Can you get to the shops? Can you walk up a flight of stairs? Anaesthetists like hearing about this because obviously it has implications for fitness for surgery. And has there been any recent change to this? So has there been any recent change from their baseline? Family history, again, very important. So any family history of any lung disease. A lot of people will come up with just some relative in the distant past who may have had something lung related. But try and focus on sort of first degree relatives, so mum, dad, sons and daughters, and obviously brothers and sisters, because they're the most relevant ones that we're concerned with. Age of death is, if appropriate, I've put down there because they may have, if someone's, for example, passed away quite young, it could be due to some tumour or some genetic problem. So it's important to ask if at what age they died, if that's an appropriate question to ask, obviously. And then be empathetic. So obviously don't ask straight in, maybe say, you pass on your apologies or say, I'm very sorry for your loss. And then ask age of death if it's appropriate. So just to conclude, I always think it's really nice to wrap up succinctly at the end, even if you haven't fully finished, because there's a mark for concluding nicely. So keep an eye out for keep an ear out for the 1 minute to go buzzer, and then try and sort of formulate your ending from there. So maybe ask the patient if they have any questions for you, because obviously you've asked them a lot of questions, and they may have some questions sort of brewing as well. And obviously thank the patient for taking the time to talk to you. They didn't have to. So thanking the patient is often a nice thing to do. So that is the end of the respiratory history. So it's sort of a brief tour of how to take respiratory history and the important things to cover. Does anyone have any questions before we move on to the examination?
You're welcome to either drop a question in the chat or you can shout out if you prefer, if there are any questions. Oh, there's one coming through on the chat. Just give that a minute. So Syed's asking, how does NSAIDs and beta blockers affect RESP?
Good question. The exact mechanism of which I can't exactly remember. Beta blockers cause bronchoconstriction. So beta blockers constrict your airways. So obviously someone with asthma, when their airways are already sort of hyper aware of constriction, that's a terrible way of phrasing it. Someone with asthma, their airways are very sort of constricted already, and they're very responsive to changes in the environment. So beta blockers cause bronchoconstriction, which obviously is worse for someone with asthma. And I think the same with NSAIDs. NSAIDs also cause bronchoconstriction. The exact mechanism of which I cannot remember, but I will have a look for you and I will message you after. I'll message you after the session. But they're both implicated in sort of the airway constriction.
If there are any more questions, feel free to drop them in the chat. Joe, I can let you know as they come up if you like.
Yeah, sounds good. Thank you. Cool. So we'll move on to a whistle-stop tour of how to do a respiratory exam. So like the history, there's a set sort of routine for an examination, which I always like to write down in case I sort of lose my way during auscultation. So start off with inspection, then palpation, then percuss, and then listen. That's pretty universal for a lot of sort of the thorax exam, so especially with the cardiovascular exam that Monica went through last week. So they're always good to write down just in case you sort of lost your way a bit. Again, be polite and systematic. Manners cost nothing, so it's important to be extra polite. Don't forget to wash your hands. And then I've put in big capital letters, chaperone, chaperone, chaperone. Respiratory exam is still a fairly intimate exam for both males and females. So it's important to consider and ask if the patient would like a chaperone, because the examiners are very hot on it. And it's out of respect for the patient, and also it's also for you as well, as the person performing the exam, to make sure that you're safe, and to make sure that someone is chaperoning you throughout the entire time. And again, read the brief from what they want from you. Do they want the anterior chest? Do they want the posterior chest? That's always an important thing to have a look at as soon as you see the word respiratory exam. They may want the entire exam. The entire exam is quite a lot to do in 8 minutes, so they may just want to do anterior chest or posterior chest. It's important to have a read of exactly what they want from you. Again, exactly like the history, introduction is vitally important. It's the first time they see you. It's the first time they see you. And sorry, I said that twice. First time they meet you. To introduce yourself, full name, wash hands. Again, like the history, introduce exactly who you are. Confirm the patient's name, date of birth, exactly like the history, and then explain what you'll be doing. So I usually say sort of along the lines of, I need to perform an examination of your respiratory system examination of your lungs. I will be having a quick look at your hands, a quick look at your face, and then a quick listen to your chest as well. So just a quick brief explanation of exactly what you'd be doing. And then it's important to ask for consent as well. So am I okay to begin? Am I okay to continue? Just be very clear and concise in asking for consent. And then consider the need for a chaperone. I always like to ask, is the patient in pain? Again, it's a nice rapport builder. And it's something that can be fixed very easily if they are in pain. Often if the patient's in pain, it'll make your examination significantly harder. And if you sort of sort out their pain, it will make the examination a lot easier for both you and the patient. So position the patient. So for respiratory exam, 45 degrees on the bed is fine. And then gain adequate exposure. So you need adequate exposure to the entire chest, so the entire thorax, again, anterior or posterior, and make sure you cover up the patient if you're not directly using, or if you're not directly sort of examining that part of the body. It's important to always be respectful. I know the respiratory exam is quite hard in terms of sort of trying to maintain privacy and maintain the patient's exposure. But it's always important to try and consider exactly what you're doing and then maintain adequate exposure at all times. So general inspection, so the sorts of things that will appear on general inspection. So usually it's good to be really clear about exactly what you're doing. So now I will generally inspect from the end of the bed. It's generally the first thing you do. So do they look well? Do they look unwell? Do they look particularly distressed? Cyanose. So cyanose is when they look blue and pale. And these can give you indications of sort of what the general appearance of the patient is. What's the nature of their breathing? So are they short of breath, or do they look short of breath? Are they using their accessory muscles to breathe? And do they have pursed lips? A pursed lip is very common in COPD patients who are very short of breath. And it's literally as it says on the tin. So are their lips pursed? And this helps sort of maintain the pressures in the lungs to try and help them oxygenate as much as they can. And do they look like they're particularly hyperventilating? This can be for numerous causes, and we'll go through a few of them later on. Do they look particularly cachexic? Obviously, weight loss is a hard one to objectively examine because this almost certainly is the first time you've met the patient. But do they look particularly thin and particularly unwell? It's important to look for clues around the bed. So is the patient on any oxygen? If they are, what sort of oxygen? Is it nasal specs? Is it Venturi mask? Is it just a normal face mask? And then how many liters of oxygen they're also on as well. Are there any sputum pots? If there are, have a quick look in the sputum pot. This might give you an indication as to sort of the sputum questions we were asking earlier. Sort of how much, what colour is it? Is there any blood? Are there any inhalers knocking around? Any nebulizers? Is the patient hooked up to the fluids? Is their cannula got fluids running through? Or any other medications for that matter? Can you see any cigarettes? Can you see any ECG machines? All will sort of give you an indication as to help you build a picture of exactly what's going on. And I put down there the last thing to look for is any obvious stigmata of respiratory disease. So are they coughing? Can you hear a wheeze? Can you hear a stridor? So stridor is obviously a medical emergency, and it's a sign of upper airway obstruction. So this is obviously it's obviously a very important thing to look for, and important thing to shout for help if you were to ever notice it. So the first thing to do once you've done your general inspection is have a look at the hands. So again, be very clear. Now I'd like to have a look at the hands. So again, the sorts of things you're looking for, are they peripherally cyanosed, which is this picture here, if you can see my mouse. This sort of gives an indication that they're peripherally shut down, and they're just not very well. Have a feel of the hands, have a feel of both hands, comparing the temperature from both hands. If they're warm, sweaty and clammy, this could indicate someone that's retaining their CO2. It's commonly seen in patients with COPD. Do they have clubbing? You might have heard of the Shamroth's window, which is that test. If you can, where you ask them to put their nail beds. Ask them to put their nail beds next to each other, and the loss of that window, that's called Shamroth's window. Loss of that window indicates clubbing. The causes of clubbing is pretty much every single lung disease you can think of, except COPD. It's a common misconception that COPD causes clubbing. So the main causes are things like lung cancer, interstitial lung disease, bronchiectasis, mesothelioma, and cystic fibrosis, so not COPD. And then have a feel of their cap refill. So make sure you press down on their nails and their fingers for 5 seconds, and then let go and see how many seconds it takes for the colour to return. Anything less than 2 seconds is normal. Anything more than 2 seconds indicates that they're peripherally shut down. So consider I mean, yeah, I put down there septic. Obviously, having a prolonged cat refill time isn't the only sign you'll get in someone who's septic, but it's something to consider. Other things to look for in the hands: do they have a tremor? So important to ask them to put the hands out just flat. I like to put a piece of paper on top of the hands. That sort of gives me an objective measure of how tremulous they are. And the common cause of this is the excessive use of beta agonists. So in respiratory tools, that'll be something like salbutamol, so commonly seen in asthmatics and COPD patients. Do they have a flapping tremor? So that's slightly different to the tremor that you get with excess salbutamol use. And this picture here is what you get the patients to. So ask them to extend their arms and then cock their wrists back. And if they are retaining, so often seen in type 2 respiratory failure, their hands will sort of flap to either side. You might have seen that in your gastro revision as well for hepatic encephalopathy, and it's very similar. Is there any tar staining on the hands? Obviously, you get tar staining with smoking. And do they have particularly thin or bruised skin, which is seen in long-term steroid use? Steroids usually in this case can be oral steroids, but most likely inhaled corticosteroids. So asthmatic inhalers and COPD inhalers often contain inhaled corticosteroids for their anti-inflammatory effects. Moving up from the hands, the wrist is very important to examine. So have a feel of both the radial pulse and the brachial pulse. The radial pulse is good for feeling rate and rhythm, and the brachial pulse is good for feeling character of the pulse. So in terms of the pulse, are they tachycardic? So are they fast? Do they have a particularly fast heart rate? This could be due to beta agonists such as salbutamol, or just being unwell. Obviously in sepsis, you get tachycardia and hypotension. So it's often useful to consider if they look septic. Do they have a bounding pulse? So this is what we refer to as the character of the pulse, which you need to have a feel of the brachial pulse for that. So someone with a bounding pulse, they're often retaining their CO2. So COPD patients often have a bounding pulse. And this is because CO2 is a potent vasodilator. So obviously you get more of a bounding pulse because all your vessels are much more dilated. And what's the rhythm? Is it in sinus rhythm, or are they in AF? Infection is a common cause of AF. So they may have a chest infection, which may have caused their AF. So that's another important thing to consider. And I always like to say here, once I'm at the wrist, I'd like to take a full set of observations and then calculate their new score. It's important to have a vague idea as to what a new score actually means. The higher the new score, the more often you need to take their observations. I think it's done by how long, so every 15 minutes, every half an hour, every hour, every 2, 4, 6, etc., etc. It's worth having a vague idea as to what that means. And this is just an ECG of someone in AF. So the characteristic findings of an ECG in AF is it's an irregular rhythm and no P waves. But I'm sure Monica covered that last week with her cardiovascular system. So these are just some of the things you find in some of the key findings to look out for in someone with a face. A face in the respiratory exam. So on the left here, we have someone with a fungal infection of the tongue. This is commonly seen in those that take inhaled corticosteroids because it's an immunosuppressant. So you're more likely to get a fungal infection such as Candida on your tongue. So it's important to have a look at the tongue. In the middle here, it's quite hard to see. So this patient has Horner syndrome. So Horner syndrome is caused by a Pancoast tumor, and it's ptosis. So you can see if you can see my foot, you can see her lid is slightly down. So that's ptosis. Meiosis is the constricted pupil. So you can see it's slightly constricted. And then anhidrosis, obviously you can't see in this patient, that's lack of sweating on the affected side. And that's caused by a Pancoast tumor. So that's an apical lung tumor. So that's, I've never seen it. I think it's relatively rare, but it's common exam question that they often like to ask. And this is quite hard to see. This is someone with conjunctival pallor. So that's commonly seen in those who are anemic. So often worth having a look, retracting the eyelids and having a look at their sclera. Other things to look out for, obviously I've covered a couple of these. Do they have a particularly plethoric face? So like red and flushed and yeah, just red and flushed. That's a sign of someone with CO2 retention, because as I said before, CO2 is a vasodilator. So they will get a very red and flushed face. Conjunctival pallor, obviously anemia. I've covered Horner syndrome. It's often worth doing central cyanosis. So you can do exactly what you did. So you can have a look under their tongue, to see if they're blue under the tongue. Again, that might be seen in something like an exacerbation of asthma or a pneumonia patient. Basically, anyone with low oxygen saturations will get an element of central cyanosis. Candida on the tongue, I've been through. Do they have pursed lip breathing? We covered that in the previous slide. And it's worth having a look at the JVP. It's more cardiovascular, but it does have some respiratory implications. So ask them to turn their head slightly to the right, and then look for the pulsation of the jugular vein. It's really, really, really hard to see it. I mean, I wouldn't be able to tell you what a raised JVP would look like, because there's multiple different waves. There's the A wave, there's the V wave, there's W wave, there's the Y wave. So lots of different waves of the actual JVP itself. That's probably a bit beyond what you guys need to know, but it's worth knowing what the causes of a raised JVP are, and how to measure for it. So you look for pulsation of the internal jugular vein, and then you estimate the height above the sternal angle. So normal is about 3 to 4 centimeters. So anything sort of higher than 3 to 4 centimeters would be classified as of a raised JVP. The way that I always think about it is it's sort of a raised JVP would be caused by a backlog of the system into which it drains. So if there's a problem with the right side of the heart, then that would also cause a backlog. If there's a PE, if there's superior vena cava obstruction, so a tumor can cause superior vena cava obstruction, and that can all cause a raised JVP.
Joe?
Yeah.
Just wanted to jump in briefly to let you know you're at 45 minutes.
Okay, great. I will speed up. Thank you. So moving down from the face, you need to have a look at the neck. So I'm sure you've all seen this picture before. This is from the University of Liverpool Clinical Skills Resource Centre. So this is just a nice systematic approach to lymph nodes. Essentially, I've classified it into, are the lymph nodes tender or the lymph nodes non-tender? So tender is a sign of infection, and non-tender can be malignancy, but also can more commonly just be age-related calcification. So it's important to sort of consider that if you get a non-tender raised lymph node, it's not necessarily a sign of malignancy. So again, just have a systematic approach to all of these lymph nodes, and it's always good to examine from behind the head. So obviously you stand here, if you can see my mouse, and then examine from behind the patient, and then to have a quick feel of each of the lymph nodes. The trachea again is very important to examine. It's maybe good to warn the patient before you do this, because it can be slightly uncomfortable, just poking down in the center of the trachea. But we need to see if it's central or whether it's deviated to either side. If the trachea is deviated to either side, it's important to try and understand whether it's deviated away or towards certain pathologies. So trachea generally deviates away from a tension pneumothorax or a large pleural effusion. So pleural effusion generally needs to be between 500 milliliters and a litre for it to cause a deviated trachea. But the tension pneumothorax is the really important one not to miss, because that can kill the patient pretty quickly, and it also has a pretty simple and effective treatment as well that can be done. It's just you stick a cannula in into the affected side, into the midclavicular space, at the second intercostal space, and you can just drain away the tension pneumothorax. And then deviated towards a lung collapse or a previous pneumonectomy. So if they've had part of their lung taken away, it can deviate towards the side of the lung in which it deviates, in which you've had the lung removed. Lymph nodes I covered a bit earlier. A tricosternal distance, this can be quite hard to measure and be quite confusing. So it's the distance between your cricoid and your sternum. So cricoid's in your neck, and then the sternum is obviously your sternum. It should be between 3 to 4 fingers in breadth. Less than this suggests that your lungs are hyperexpanded, and you get hyperexpansion lungs most commonly in patients with COPD. So again, adequately expose the patient, and then have a much closer look at the chest. So do they have any scars? Have they had any small mid-axillary scars, which may have been a chest drain in the past for fluid or an empyema or anything like that? Do they have a lateral thoracotomy scar? So that's a big scar coming around the side there. And that's often used for when they take out a lobe of your lung. And do they have a pacemaker scar? So just beneath the clavicle is where you'll see a pacemaker scar. Do they have any chest deformities? So pectus carinatum and pectus excavatum. So what we can see here is pectus excavatum. So their chest looks like it's been excavated almost. And pectus carinatum is the opposite. So it's more of a domed shape. And then scoliosis, obviously you'll need to look at the back to see scoliosis, but that can affect respiratory function as well. It's important to note if they've got any flail chest. A flail chest is when you've got part of the rib that's sort of like a floating rib, that's not really attached to the other ribs, that's broken in 2 or more places. And this is commonly seen in sort of heavy trauma incidents. Are they using their accessory muscles, and do they have any radiotherapy tattoos? So look for little dots. That's just like a normal tattoo, but little dots that may have indicated that they may have had radiotherapy in the past. So palpations, an important one to go to next. So this measures 2 things, so chest expansion and apex beat. So we'll start with chest expansion first. I remember the first time I learned this, I thought I only had to do it over just over the chest in general, but you need to assess all lobes of the lung. So as the picture shows here, it's important to sort of wrap your hands around the rib cage and then bring your thumbs to the middle, and then ask the patient to take lots of deep breaths in and out. And then you look at your thumbs to see if your thumbs are moving equally on both sides, and then when the patient breathes out, do your thumbs sort of return to touch each other. Unilateral loss of chest expansion can be seen in many conditions, in pneumothorax, pleural effusion, pneumonia, collapse, basically anywhere where there's problems with the respiratory system in terms of like the mechanism of breathing. So it's important to look for the unilateral loss of chest expansion. If they're hyperexpanded, again, as I said, COPD, so you may not be able to even wrap your hands around their ribcage because they may be so hyperexpanded. But it's important to, both on the anterior chest and the posterior chest, to look and to measure chest expansion on each of the lobes of the lungs. And then apex beat, again, Monica probably covered this last week. So this is important in assessing mediastinal shift. So a deviated apex beat, so usually seen sort of 5th intercostal space, mid-clavicular line, can be seen in like a collapse or a big tension pneumothorax. Apex beat can be quite hard to feel sometimes, even on a normal patient. So it's important sort of is it sort of significantly deviated either towards the center or away from the center, and that can indicate whether it's a big collapse or a big tension pneumothorax. So percussion. So this is I'm sure you've practiced your technique. The people in clinical skills tell you to practice on your wall. So this is the way you tap on your middle finger. The most important thing to remember here is it's important to compare on both sides. So not just go down all of one lung and then go down the other lung. It's important to just test each side and then work all the way down. Make sure you're covering all 3 lobes and especially the basis of the lungs. So start in the supraclavicular fossa because people forget that that's where the apex of the lung actually is. So you need to percuss in the supraclavicular fossa just there, and then work down comparing each side in turn. As I'm sure people in clinical skills told you, all movement should come from your wrist, and the striking finger, so I use my middle finger, shouldn't change in shape, and it all comes from your wrist. There are some classic findings. So if you've got consolidation, so things like pneumonia, malignancy, it'll be fairly dull. A collapse will also be dull. A pleural effusion, so fluid in the lungs, that's sort of classified as a stony dull. I've always found it really hard to differentiate between a dull and stony dull, but that's the sort of the textbook characteristic of a pleural effusion is stony dull. And then pneumothorax and emphysema, so that's just excess air, will be sort of slightly hyper-resonant. So it's important just to practice and have a list on the internet as to what these sounds actually sound like. But they're the main sort of pathologies you should be looking out for when doing percussion. So the next thing to do is obviously have a listen to the lungs. So use the diaphragm of the stethoscopes. That's the big side. Unless they're sort of very hairy, when actually it's probably best to use the other side. And again, listen in exactly the same places as you percuss. So start on the apices and then compare either side and work all the way down to the basis of the lungs. Asking the patient to breathe in and out through their mouth is key. If they breathe in out through their nose, you can often get some sort of excess residual noise, which can make examining the findings quite hard. So there's a couple of things to consider when auscultating: quality of the breath sounds, volume of the breath sounds, and then any added sounds. So quality of breath sound. So this is vesicular and bronchial breathing. So vesicular breathing is a sort of a prolonged inspiratory phase followed by a shorter expiratory phase with no gap in the middle, and that's just normal. That's just normal breathing. Whereas bronchial breathing is abnormal breathing. It's a harsh, loud, blowing character, and where inspiration and expiration are the same in length, and there's a gap in the middle. And the way to practice what this sounds like is just listen over to someone's trachea, and that is what bronchial breathing sounds like, and that is abnormal. So you get that when you're listening over someone with pneumonia, someone with a mass. You'll hear bronchial breathing over those areas. Volume of breath sounds. So can you hear breath sounds? Are there normal breath sounds? Are there reduced breath sounds? And then if so, is it in just the one lobe? Is it in the entire lung? And reduced breath sounds are seen where there's reduced air entry. So there's reduced air entry into the lungs in someone with a pneumothorax, if there's been a collapse, obviously, because there's less lung tissue to help with the mechanics of breathing, or whether there's an effusion. So anywhere where air can't get to properly, you'll hear reduced breath sounds. And then a couple of added sounds. So wheeze is the main added sound that I spoke about briefly earlier with the history. So this is a continuous whistling sound caused by obstruction or narrowing of the small airways. It's most notable during expiration, so it's important to particularly have a listen to it when the patient's expiring. And then it can be monophonic or polyphonic. So monophonic is just one tone. To the wheeze, this is more commonly an obstructing mass, so you've got to consider a tumour. It's not always tumour, but it's something you've got to consider. Whereas polyphonic, because it's more of a widespread small airway disease, so there's lots of different airways, lots of different bronchioles of various sizes that are affected. So there we're thinking something like asthma. And then if it's an inspiratory wheeze, this you need to consider, is the patient having stridor? So that's more commonly caused by an upper airway obstruction. So is there a foreign body? Is there a mass? Are they in anaphylactic shock? So they're some of the things you need to consider. Crepitations as well. I'll cover this quickly because I appreciate I'm running over time, so I'm sorry I'm taking a bit too long. Crepitations are caused by excess fluid in air spaces. So actually how you hear crackles, so crepitations and crackles are the same thing. So during expiration, the small airways collapse due to the loss of stability of these airways caused by the fluid. And then when the patient breathes in, the high pressures that happen when the patient breathes in. They force the collapsed airways open, which causes the crackling sound. So coarse crackles is often seen in someone with pneumonia, bronchiectasis, pulmonary edema, so basically fluid and gunk in the lungs. And then the classic fine end inspiratory crackles. So this sounds more like, you'll hear loads of different weird ways to describe it. And that's more things like pulmonary fibrosis. So like tissue paper, some people describe it as like crinkling tissue paper. Whereas coarse crackles more sounds like bubbles. But it's important, but have a listen on the internet. There's loads of different examples of on YouTube and things of coarse and fine inspiratory crackles. Pleural rub, I've never heard it. This is sort of a creaking sound that appears when the parietal and visceral pleura, obviously the two pleuras that surround the lung, when they rub over each other. Usually they're very smooth and they've got fluid which lines them. So when they do rub over each other, when you breathe in, it sort of glides over each other. But over time, if the lung's been sort of damaged, or if there's been lots of inflammation or lots of disease, they can become roughened and fibrosed. And this classically sounds like walking on snow. So it's sort of like that crunch of the first time with we walk on snow. It's pretty self-explanatory. And pneumonia can cause this, and the PE can cause this. So it's just another thing to look out for. I think this is the last thing I've got to cover. So whispering pectorilatory, this is the long, complicated name for basically asking the patient, say 99, when you put your stethoscope to their chest. I put to your chest, it should be to their chest. So again, listen exactly the same locations as auscultation and percussion, and ask the patient to say the word 99 at the same volume each time, because obviously that can affect your findings. If the 99 suddenly sounds increased in volume over a certain area, that suggests that where you're listening to, there's increased sort of lung mass and increased tissue density. So that would be something like in consolidation or tumor. And if there's reduced volume, this suggests presence of air or fluid underneath where you're listening to, and that is seen in pleural effusion or pneumothorax. Extra bits just to finish off. Have a look at the bottom of their back if there's any sacral edema. Have a look at their feet if there's any pedal edema, both seen in right heart failure, and have a note as to where it goes up to. So is it mid calf, mid thigh? Does it go all the way up to the abdomen, for example? And have a feel of their calves. Are their calves painful, red, swollen, which could be suggestive of a DVT? So again, conclude, summarize, thank the patient for their time, do a nice concise summary of the important findings that you've found, and the important negatives that you've also found. And then there's just some further investigations that you can say they may ask for them or they may not ask for them. But just some respiratory investigations that are sometimes good to say. So that's a nice little summary that I've just put on about all the examination findings from palpation, percussion, auscultation, and whispering pectorilatory that you may find in a normal chest, consolidation, pleural effusion, or pneumothorax. So that's just there for reference purposes. I've got a case to run through. I appreciate I'm a bit over, so I'm happy to stop, but I'm happy to carry on whatever people would like.
So it'd be nice to hear from some people if they want to go on, they're welcome to. But do people want to leave now? I've just dropped the little link to the feedback form, which should take you a minute to fill out, which we'd really appreciate it. So we're getting some people saying carry on, want to do the case. Yeah, so people are free to leave now if they want. Please fill in the form if you can. If not, you're welcome to stay and we're going to go through the case if that's okay with you, Joe.
Cool, yeah, of course it is. I'll be as quick as I can with the case, but I thought it was just quite an important topic to cover because it comes up quite a lot in exams and OSCEs and whatnot. And there's some important things I just wanted to signpost people to. So a 21-year-old male presents to the GP with a 4-month history of increased dyspnea that is worse on exertion. He also complains of a sporadic cough and a tight chest, particularly when he exercises. What is the most likely diagnosis? Happy for people to shout out.
So we've got a lot of people saying B in the chat.
B, exactly, asthma. So things that point towards asthma, the age of the patient, some triggers here, so shortness of breath, worse on exertion, quite a chronic history, so 4 months are quite a long time, and you has a cough and some chest tightness, and we've got a trigger here, so when you exercise, so yeah, asthma. So again, so features of asthma, so typically it's a young patient, a non-smoker. It's quite a common question getting exams, what's the difference between asthma and COPD? So they're just a couple just straight off the bat. So typically asthma is a young patient, a non-smoker, whereas COPD is generally, not always, an older patient who smokes. You get diurnal variation of asthma. So as I said earlier, it's worse in the morning and worse in the evening. Dry cough, shortness of breath. They may have a history of atopy, so hay fever, eczema, and there may be a family history of hay fever and eczema. And again, episodic symptoms, so not necessarily symptomatic all the time, but symptomatic when they're running or they're exercising or they go out in the cold or there's dust or pets and things like that, as I mentioned earlier. On examination, they'll have a polyphonic expiratory wheeze, and they might be tachypnea, so they might be breathing quite quickly. So what sort of investigations could you perform on an adult who comes in if you're suspecting he might have asthma?
So people are saying you can try spirometry with reversibility.
Yeah, yeah. So that is the best. That is the best one. Yeah, peak flow, exactly. So I've sort of answered this like an ostomy station. So what investigations would you do on this patient? So I take a full history and I'd do a full respiratory exam. And then yeah, exactly. So spirometry with reversibility. So spirometry is where you blow into is where you basically breathe into a machine, and it gives you your FEV1 FVC ratio. In someone with asthma, that would be above 70%. So that would be an obstructive picture. And then you think, right, I need to see if this is reversible. So you give them some bronchodilators, so give them some beta agonists, and then measure their spirometry again. And NICE, so this is taken straight from the NICE guidelines, and NICE say if you have an improvement in FEV1 by 12% and an increase in volume of more than 200 milliliters after you're bronchodilated, that is a positive test. So that is indicative of a patient who has asthma. You can also do a fraction of expired nitric oxide test. So again, you just breathe out. Asthmatic patients breathe out higher levels of nitric oxide, just due to the higher levels of inflammation in the airways. And the cutoff is greater than 40 parts per billion, and that is indicative of a positive test. You can also ask them to do peak flow. So that's just the breathers hard and fast as they can into the tube, and the little dial goes up. But we like to measure peak flow variability. So more than 20% variability over 2 to 4 weeks is indicative of someone with asthma. And then slightly further down the line, in terms of less useful tests, is the bronchial challenge test with methacholine or histamine. So you give them methacholine, you give them histamine, and then you measure, and then you see, and then you sort of see how they get on. That's much further down the line, and that's generally done in a specialist centre. So these three here, they're the main ones to remember, main ones to consider. So how would you manage this patient? It's the question that everyone loves to hate in medicine, is asthma management. So how do you manage how would you manage this patient?
So you could give salbutamol.
Yeah, exactly. Oh, reliever, PRN throughout, ICS. Yeah, exactly. So the one thing I wanted to flag here before I go on to this is there are two different guidelines for how to manage asthma. There's NICE guidelines and there's the British Thoracic Society guidelines. It's important to recognise that there are two, because you might see slightly different conflicting ideas. It's important to recognise that there are two. I've written down the NICE guideline, so I've linked it down here so you can go straight to it. And NICE say, yeah, so you start off with a short-acting beta agonist, or something like salbutamol. If that doesn't work, so this is all sort of a step-by-step ladder. So if that doesn't work, you'd add in an inhaled corticosteroid. Excuse my typo there, that should be an S, such as beclometazone. If that still doesn't work, you can add in a leukotriene receptor antagonist. So you add in for 4 to 8 weeks and then review. For example, montelukast. If that then doesn't work, you can then add in a long-acting beta agonist. So instead of a short-acting, you add in a long-acting, such as salmeterol. So slightly confusing names between salbutamol and salmeterol. And then you can review what the leukotriene receptor antagonist is doing. Is the montelukast working? Is it working slightly? Is it not working at all? So you can review whether you need to stop that or carry it on. And if that doesn't work, you start something called the MART regime, which is a low-dose inhaled corticosteroid with a fast-acting, long-acting beta agonist. So it's a bit of a mouthful. But when you start getting to this point, then you need to consider you do need senior input or referral to a specialist centre. I appreciate there's no quick way to learn this. Unfortunately, it's just a memory, just sitting down and rote learning it. But I just wanted to flag that there are two different guidelines. So if you see conflicting evidence and conflicting answers, that there are two different guidelines. I've just put some side effects for salbutamol and side effects for inhaled corticosteroids, and they're worth considering as well. So the same patient then represents to a GP practice 5 months later with sudden onset dyspnea, a worsening of his wheeze and severe chest tightness. He says he's struggling to breathe. His peak respiratory flow rate is 45% of baseline. His respiratory rate is 32. He's struggling to complete sentences in one breath, and his oxygen sats are 96% on room air. How would you classify this patient's asthma attack? So I'll go back to it. Oh, sorry. Oh, I've just given the answers. Sorry, that's my fault. I'll go through it anyway. So yeah, so this patient. So these are the criteria for moderate, severe, and then I've got life-threatening on another side. In fact, there it is. So moderate asthma attack, you look at peak respiratory flow rate, so is it between 50 and 75% of baseline? And the other important thing is no features of severe asthma. So severe asthma, you look at peak respiratory flow rate between 33 and 50% of baseline, which is why it's important that upon a new diagnosis of asthma, we need to get a baseline of what their peak respiratory flow rate is. They have a respiratory rate of more than 25, so they're particularly tachypneic, and they're very tachycardic with a heart rate of greater than 110, and they struggle to complete sentences in one breath. So they're the features of severe asthma. So this patient had severe asthma, and then life-threatening asthma is a nice little mnemonic, is 3392 chest. I'm sure most of you have heard that before. So 33 refers to the peak respiratory flow rate, so less than 33% of baseline. Saturations refer to, the 92 refers to the oxygen saturation, so their oxygen saturations are less than 92%. And then chest is a nice mnemonic, so C for cyanosis, so they'll be blue. They're struggling to breathe, so they're, and their sats are low, so they'll be cyanosed. They'll be hypotensive, they'll be exhausted, so because of their tachypnea, they'll be breathing so fast for so long, and they'll just get worn out because they're muscles and muscles can tire, so they'll just get worn out. They'll have a silent chest, so they'll have reduced breath sounds going into their lungs, so it's important important to consider. And then they'll have tachyarrhythmias, so they may have arrhythmias on their ECG. It's also important to consider the patient who's having an asthma attack that has a wheeze, and then suddenly you treat them, and then their wheeze goes away. It's important to consider that group of patients isn't actually tiring, and that actually the silent chest is that the patient is just having reduced air entry into both lungs. So it's important to sort of consider these life-threatening and make sure you rule out all of these life-threatening symptoms. And if they have any sort of life-threatening symptoms, then call for help and treat immediately. Which brings me on to my final and last question. So I appreciate I've gone way over, so I'm very sorry for keeping you all. I'll just go on to, so these are straight from the NICE guidelines of how to treat an asthma attack. So there's a nice mnemonic again. It's quite rude, so I'm not going to say it on this, but I'm sure everyone has their own way of remembering it. Oxygen, if you're hypoxic, so if the patient has SATs less than 96%, then we need to give them oxygen. First line of treatment is salbutamol nebulizers, so 5 milligrams of salbutamol nebulizers, and then oxygen driven if possible, because it sort of kills two birds with one stone. Steroids are an important treatment of an acute asthma attack. So prednisolone 40 to 50 milligrams would be pretty much started immediately. If they can take oral medications, then this works. They may be too tachypneic to take oral medications. And a patient with an asthma attack usually takes prednisolone 40 to 50 milligrams for at least 5 days. You can also add in ipratropium bromide. That's again another sort of anti-inflammatory for the airways. And that is again 0.5 milligrams. And again, that is given as nebulizers. And if this still isn't working and the patient still looks particularly sick and particularly unwell, you can give magnesium sulfate IV. And it's 1.2 to 2 grams over 20 minutes. But this should be done with specialist input only. So specialist respiratory physician, anaesthetists, so very senior doctors and clinicians who are used to dealing with things like this. And that is it. And I've come to an end. So I'm very sorry for keeping you all so late. But I hope that was useful. And I'm happy to take any questions if anyone has any.